little bit about what you've done. We appreciate what you have done. Certainly your letter of support for our grant.
Congratulations, by the way.
It's pretty exciting.
200,000, right?
Mm-hmm.
Yes.
Yes. Our grant writer, Christy Albertson, left about an hour ago sick.
Oh.
Otherwise, she would
Oh.
have been here.
Tell her thank you and good work.
She really has made a difference because we've been able to get more money than we planned on a lot of things, which is good.
Yeah.
Because Lake County needs all the help. So we appreciate your letter of support. We have a little bit of information about the grant that we are applying for. We have some information about the program that you're doing.
Yep.
And so what we really wanted to do was, with you being here, give you a little bit of information, our thoughts on what our goals are. And then, certainly, thank you for your support. We have a lot of things that we're working on. We're very proud.
He was just giving me the cook's tour. That's why we're a few minutes late getting in the room. It's impressive. Well done. Pretty exciting stuff.
One of the things that is different, that I don't think when you were here last, we've talked a little bit about it at other times. The health district now not only is responsible for acute care, but we also have the responsibility for mental health and most recently, public health. That's a unique thing for our
So
community.
you got it all wrapped, everything wrapped into one.
That's correct. That's correct. Trace is in charge of our wellness service, which we've now renamed, mental health, but we've renamed the wellness center. And she can talk a little bit about that. Daryl can talk a little bit about some of our addiction issues, some of the issues that we deal with. And we've got all sorts of other people that can talk about things that.
Maybe she could come up around the table. Well, by the way, this is Larissa Bounds, who's my chief of staff.
Hi.
Who's out from DC, but hails from Hermiston, Oregon, so.
Should we start off with Trace talking a little bit about what our wellness center is doing?
So thank you for your time and your service for our state, Congressman Walden. When the hospital took over 2 years ago, we went from serving 199 people to currently we're serving 349. So we've greatly improved our access to our services, and we're in the process of integrating with PCPs and other community partners to improve partnerships and access and getting folks in when they need it.
Were those other people not being served prior to that, or being served by their providers?
They were not being served
So
previously.
nearly double.
Mhm. And when they changed the name to wellness, the whole point of that was to break the stigma, and we've been working on that, providing education and presentations in the community to help educate people on our services and what to look for when they need services.
Mhm.
We're also working on some projects like increasing housing, jobs, supported employment, and outreach services to try to connect with people in those rural areas.
I'll have a question for you later on.
Okay.
Trafficking, what you may or may not run into. It's another issue we're focused on.
Trafficking?
Yeah, I did a roundtable in the Grand and was just stunned. There were some victims there, young women, and what they encounter, and it's just stunning. And they said, it's right here in Elgin, it's right here in the Grand. And we passed a lot of legislation to deal with it, but anyway.
Isn't Portland one of the centers for
Could
trafficking?
very well be,
On the west
yeah,
coast?
wouldn't surprise me a bit. So, anything along the freeways, I think,
Mhm.
75 or something.
Yeah, I've actually had a client when I was practicing in Klamath Falls that was a victim of that, so yeah. Also, in order to help with the problems that we're seeing in this area, our philosophy is that emotional pain is hooked to chronic pain, And we definitely want to get out more education on our programs through SUD. And currently, well, when I started, we had one SUD provider, and that was Susie. And since then, we have gained 2 more staff, and we're looking to hire 2 more staff for the SUD program.
Okay. And you know, in the legislation, we expanded the provider base that can oversee the administration of Suboxone and medically assisted treatment development. Great to help provide more services in rural areas, more people who can oversee the services. That was something that really came out clear to like nurse midwives, you know, across the spectrum. So they've got the right training, but it's dramatic expansion. Because the one thing we heard consistently was there's just a lack of access to people to help people with substance abuse and trying to. And there's a woman in Hermiston that told me she drove 5 hours to Washington State to find a provider who could help get her off the opioid addiction, at least on Suboxone. She's now part of their group on opioid. She's like internal working in the healthcare world. But it was pretty powerful situation.
And we have a provider that we're going to bring on site on Friday that we're hoping to hire. It's a nurse practitioner. We're hoping to get her trained in Suboxone and do the MAT program. Also, along with breaking the stigma and education, we've been doing some different projects. We had a veterans suicide prevention picnic that went really well. We have a veterans dinner that we're going to present at. We're planning on targeting schools and more community members in presentation. That way the word really gets out.
It's a real unmet need, especially on the mental health side.
Mm-hmm.
We put a lot of money in the most recent appropriations for veterans for suicide prevention and treatment, mental health services, and directly into opioids and other substance abuse treatment. So we're trying to get that out.
Are they required to go to VA facilities to get into that, access those programs, or can they receive that service outside?
That is a good question. I think they can do it off choice, VA choice program. But we will, I'm going to run that out.
Because out here, we're a long distance from White City.
Yes, we are.
And when you think, as Trace talked about, access, one of the problems you get is take somebody who has a substance, gets a DUI, and they don't have a vehicle, they don't have any way, they don't have public transportation. How do they get to their treatment?
Right. We also tried to break down some of the barriers for telehealth, including payment barriers and all, and expand access for both veterans and non-veterans for some of the counseling, which I believe the data show actually works pretty well. Telehealth, telemental health, and so we're expanding that and trying to break down barriers where they exist in various. There are a few rules in healthcare. I don't know if you've all run into any of those, but a few extra regulations more than you need. But we're trying to break those down, and just because of that access for folks in rural areas like our district.
That's excellent. Susie, you're...
Yeah, did you have anything else?
We're also working on trying to alleviate barriers such as the transportation, and we're working with Gobi right now to try to get smartphone access.
Oh yeah, that makes sense.
So those are a few of the things, and we're really looking forward to the survey to see what gaps we're missing, but we're trying to be as proactive as we can in alleviating those barriers.
So are you finding, what percent of what you're dealing with in terms of the drug side of the world is opioids? What percent would you say is methamphetamine or other?
Well, they're all very prominent. It seems in our particular area that meth is number one, followed by fentanyl, heroin, and opioids, but Daryl can speak more to that than I can.
And just know, by the time we were done with the opioids bill, which the President signed last week, we went from an opioids bill to a drug bill. So basically, it's a substance abuse disorder bill in the sense of we opened it up to whatever whatever the issue is, it gets covered by.
Perfect.
So it's not specific to opioids anymore. We kept expanding it out. If I said, what are we doing? Stone or fireball or stovepipe and stuff. So it's much more broad.
That's great.
Through evidence-based practice, my staff and I, we treat all types of addiction, not just opioids, but, and methamphetamine is the big thing in this town. But once you take methamphetamine away, then they'll go for a different drug like opioids. And now that the providers have cracked down on prescribing them, we have more of a chance for heroin abuse to move on. From my perspective, you know, I am looking forward to working with some of the providers we have in this community. We have some great providers. And I think that being able to address those physiological as well as the psychological aspects is so important. And I think our crew we have the talent and the ability to do so. We were through, with Mr. Gurr, we were in treatment court with some of these folks who suffer from addiction. And we're able to offer them a second chance at pretty much life. And Jake and his crew are just fantastic people to work with. So, and moving forward, you know, I think that medication-assisted treatment is on the horizon for us, and I'm looking forward to it.
Well, Congressman, the only thing I can tell you is that I do see a little bit more opioid use now than when I first came here. It was mostly meth, and so we're seeing a bit more of that. And I know that we're working on continuity of care now, which is really, makes me feel good because I feel like we're going to have better success.
Yeah, no, that's good. You know, I had a roundtable up in Baker City recently, and one of the physicians there talked about how sometimes people with mental illness it was just easy just to prescribe opioids. And now they realize just what a mistake all of that has been, and really changing behavior as a result. So hopefully we're taking better practices and best practices.
One of the big things we're trying to do as we look to break down some of the barriers, if a physician is real busy and has a patient that has a mental health issue or a substance use issue, we can do warm handoffs right in the clinic.
Excellent.
And quickly get in. Daryl has been in clinic for a little while.
Yes.
It's easier if they're right there. Jane Lincoln is not here, but she's in the clinic wherever possible. But what that does, if you say, well, why don't you go and see the folks at wellness? Well, the number of people that actually go drops off right after the visit.
Yeah, yeah.
But if they're right there,
Yep.
then we coordinate much better.
Well, and that's one of the issues I've heard too, that just getting access to that treatment, that care, can be weeks or longer. You know, when somebody's ready, you know this far better than I, but I'm guessing when somebody says, I'm ready, you better get them in. That's ready to test yourself. So that integrated concept makes a lot of sense.
And to add to that, second fold to that is a lot of our primary care providers are trying to address the behavioral health needs of the patient. So having that help there of a social worker to take that on relieves that little bit of pressure from our primary care providers to focus more on the physical health aspect of it. So that has really helped. And we just added the social worker, Jane Lincoln, last month, and we have had some successful handoffs, and we are seeing an improvement in that. Yeah. We are working hard to keep half of her day as open access, and then other half to have scheduled patients so that she's available half a day, every day, to be able to do warm handoffs. So that is really great, and we are working with Gobi on that. It is a very new concept of behavioral health integration, which has probably been around for some time, but new to us. But it has been successful so far that we have. So that's really good.
It was interesting in this meeting in Baker, they were talking about behavioral health and the integration there and some data that just, it's not huge, but they're seeing great outcomes improved outcomes. And it's everything from just counseling people that pain is sort of a natural thing, and, you know, just helping people understand that there, you know, there is no silver pill for all pain. And then they're working on lots of alternative pain strategies, yoga, other things to assist in getting a good response.
And our primary care providers have started looking a little bit more towards the box-on training. So out of the 6, we have 4 of our providers who are certified for that, and 2 more are on their way to get certified. And hopefully when the psych nurse practitioner comes on, that would help us to transfer the patients for long-term counseling with the psych nurse practitioner as well. And in the last year, we have done a lot more in the primary care area to be a little bit more vigilant on the opioid prescriptions. So as Daryl and Trace were mentioning, we do a lot of checking on PBMP, the statewide opioid system, and we also look at the CURE system, which not all of us have access to. That's the state of California opioid system. So really what would help us is if there was a nationwide system, then we can look at, since being on the borders, we have patients from California that are sort of here. But in the last year, we have made a lot of improvements in doing that and catching patients who are trying to sort of seek opioids.
Yeah, we're trying to expand the PDMP process, and we recognize the cross-state issue. And then we also, we had some legislation to allow more empowered pharmacists when they think there's something up to not issue the prescription until that gets resolved. So I mean, there's some more sort of gatekeepers here. We're trying not to deny medicines to those who really need it, but to try and get at the issue of the fraud and the abuse that's there.
And it has really helped working with Teresa's team on the acute and the ED side is being able to share that data from the PDMP being automatically going into our EHRs in the ED has also helped us address that, because we have the same providers in the clinic that are sort of covering our emergency department. So having that access to knowledge of if the patient already has a pain contract somewhere else has helped providers provide better care.
One thing we did not get in here, we passed it in the House, but it's still stalled in the Senate, was dealing with Part 2, 42 CFR Part 2, 43 CFR Part 2. This is the people who are in substance abuse treatment, their medical information gets sort of warehoused over here, and it does not flow across the medical records. There have been people who have been in treatment who subsequently get medical care somewhere, and that provider doesn't know they're in treatment or have been in treatment. They get an opioid overdose and die. And so we tried to, we passed it in the House that it was overwhelming vote. We put all the safeguards around medical privacy, actually more than exist under HIPAA, and then this information could flow. And I think we got, I don't know, over 340 votes or something. But the Senate, we've got some more work to do there. Patty Murray in Washington State is not a fan of it yet. And we had a bunch of people who were nervous about it because it is medical privacy. And you don't want somebody in treatment having that used against you in your employment or your housing. And boy, we put tougher firewalls there than exist under HIPAA to prevent that. But we also have this problem with providers not knowing. And you got to sign off every time your record gets is going to be moved around, and that isn't always practical. So,
Have you been thinking much about what to do with people in crisis that are in, we have a locked unit, which gets used a fair amount.
yeah.
But we have a hard time finding a place to put them after they've been evaluated. Police don't want them. We have them. Puts, from a safety standpoint, puts a lot of our staff at risk. Has that been an issue that you've heard?
It has been. It's all over. I heard it in Pendleton last week when I was in Pendleton, or a week before. You hear it everywhere, just a lack of mental health beds, frankly. And then residential beds for mental health as it relates to substance abuse. And so that we're trying to change the Medicaid prohibition on IMD that limits to a certain number of beds, how many people that can be in mental health and / substance abuse in one unit. It was put in place sort of as the overreaction to the 60s when we just warehoused anybody that we thought had a mental illness. So then we went too far the other way, and now we need those residential beds in many cases. So the state can get a waiver, they're seldom granted, and it's a cumbersome process. We wanted to open the door to make that easier because we were hearing that. And so we did, but it's pretty much, I've forgotten the total number you can get to, but it got kind of tightened down to pregnant women and they identify classes of people, and it's like, all right, that's the best we can do, we'll take it. But the administration understands it, CMS understands it, and I think there will be more flexibility granted from SEMA at CMS if states want to apply for a waiver to have more beds. And people in that business, and I'm not, tell me that if you could get a few, there's a certain bed size where it makes sense fiscally, and that's not what the Fed's limit to right now.
It's at 16, it could be up to 24.
Right. And if you can get a little larger, you can make facilities operate in black. And so we're trying to get to where we have the right services for the people that need service.
Well, we certainly encourage you to keep that fight going,
Yeah.
because that would be really helpful.
Yeah, the two biggest fights in the committee were over IMD expansion and Part 2 waiver. And they came out of committee a little wobbly, but by the time we were done on the House floor, they both had overwhelming bipartisan votes. Leaders of both parties supported them. I think there were only 40 or 50 no votes out of 430. So, I mean,
But the Senate is still working.
we got the IMD a bit, but the Part 2 bill is over in the Senate. We kept it out of the overall opioid package because it was controversial. And so it's still pending. So my goal is when the elections are over, and I'm not counting 8 days, but when that's over, then I'm hopeful. I've talked to, I was with Lamar Alexander last week at the White House when the president signed the opioids bill. We sat next to each other, and I said, we gotta figure out how to get this done, Lamar. And he's open to it. There are just some members that aren't. And so, just as in the House, we had to go educate ourselves and then our colleagues. And when we did, we all kind of got what needed to be done for better public policy, and that's why it passed overwhelmingly. And I think we just need to do that in the Senate. And the provider community really needs to ramp it up. And there aren't that many holdouts. I think if we can get it on the floor of the Senate, it would pass overwhelmingly, just like it did in the House. It's just Lamar and Patty Murray, who's his top Democrat, they kind of have an agreement that if they're both not in agreement, then it wouldn't go in. There you go. So we have some work to do with it. But if you can reach out to any senator anywhere, anytime, this would be the time, because when we get back in session in 2 weeks, I want to
Do you know how our senators are?
I don't know that they're opposed to this. I haven't talked to them recently. I'd have to go back and check with the staffs. But I don't know. Do you know?
Yeah, I was just thinking, I don't remember what.
You might ping Nolan and see if he knows. The real key here was Patty Murray of Washington because of her position on the committee of jurisdiction. And my hunch is if we could get her, then it'd be like the House. We never did get my ranking Democrat on the committee to support it, but even Leader Pelosi and Steny Hoyer, the top Democrat leadership in the House, all supported this on. I told my team, I said, if that had been me, I'd return to my staff going, now tell me again why I was opposed to this. If your entire leadership votes the other way, it's like, so what did I miss here again? What were you telling me? So it's just, but people are rightfully concerned about medical privacy, especially when it comes to mental health and substance abuse treatment. It's an area we want to be very careful in. But frankly, the safeguards we put in place around Part 2 are stronger than HIPAA safeguards, which most people say may be maybe at times even too strong.
Good. Well, certainly one of the things about our grant that is important is to include Klamath County as well as Modoc County.
Excellent.
Because while we share lots of things together, it's like whack-a-mole. You hit one place, sure, pops up someplace else, and we don't want to do something to harm our neighbors in any way, shape, or form. And of course, our survey is going to be handled by OHSU, who are, if you ask me about where to buy drugs, I would not be able to answer very intelligently. I don't know. But OHSU, I guess, can ask the right questions of the right people.
So we are working on different vendors, but OHSU is one of them, and they have worked on the research program with different vendors who have done opioid-related surveys in the past. So reaching out to them and seeing if we can work with the same vendor would be very helpful, and that's what this grant will help us do.
And what are you trying to identify? Who's buying and who's distributing and?
We are mainly trying to identify the gaps in the opioid services, like do they have enough access, what kind of challenges do they face when they want to get access to a pain clinic or mental health services. So it's mainly identifying gaps and challenges that the community faces. And once we identify those gaps, we can work towards a solution to help close those gaps. But I think with the planning grant, our main goal is to work on that survey. And the other big piece of the grant is going to work with law enforcement and giving them all the tools they need and the training that they need if they come onto a crisis.
Yeah, I was going to say, do your officers here travel with naloxone?
So in Lake County, the North County officers do, South County do not have access to that. So this grant will help us fund that and training for that.
And do you know, is there any kind of law enforcement consortium to group purchase naloxone or work with some of the agencies that do grants on?
I am not very sure.
Jake, do you know?
I believe there are some grants out there. I'm not sure the state, Oregon State Sheriff's Association, and the Chiefs of Police Association, where they're at with those. I know within community corrections, there hasn't been a lot of, unless we're a community corrections agency statewide, there's some under the sheriff and some that are standalone. Those under the sheriff, I believe, have access to some of that.
Go ahead.
We haven't had that, but I know some of the law enforcement here has had, have deployed that and had astounding results with it. So,
If we can be helpful in that, I'm happy to do it. I know the Umatilla County Sheriff got a grant from, ironically, Purdue Pharma for naloxone. Purdue Pharma is the father of OxyContin. Have been under investigation. We have them under investigation, but others have too. But through their outfit, they're now providing naloxone to various law enforcement agencies. So that's something you might check with the sheriff there in Umatilla County, because they did get a grant 6 months ago, years ago, something like that.
So Klamath County actually has an opioid task force. And probably, Valerie, you can speak a little bit more to that.
Yeah. We actually have a task force, but in the recent months, they have not been active. So upon receiving the partnership with this grant, we decided to reactivate that task force, and we'll have our first reconvening in November. And so that's going to include some of our both sheriff department, local police department, possibly the state agency, and then also we come from the hospital side. We work at Sky Lakes. We're bringing that along with public health agency and then a few other representatives back together. And now that we have this grant, this planning grant and the partnerships, we feel like we'll be able to move forward. And I just wanted to touch on something else that we've been doing. In Sky Lakes, we have Lean Six Sigma, and we also do quality by design projects. And the quality by design project that we're currently working on, actually Callie and I are kind of the lead navigators for that project. It's called HELP, which is Holistic Evaluation of Lifestyle Planning, but it's actually surrounding opioid reduction. And so one of the objectives of that process was to set and establish guidelines very similarly to the CDC and get those implemented for the PCPs within Sky Lakes family. And then hopefully get the remaining clinics in our region, in our county, to also follow suit. So we have now established that, and it's going in front of the board. And so it has not been, I believe, approved yet as consistent use, but a lot of the PCPs are adopting it. and it's going to be kind of our gold standard. And so the other thing that we focus on is alternative methods for managing chronic pain
Yep.
other than drug use.
Yep.
And so our clinic, we hand select currently and work with our CCO, and the CCO has extended additional resources for us, for those people that are participating in the pilot, to see how those are going to work over a 1-year period. So we're taking 20 patients initially in our pilot, and we'll examine how that process went. We have a panel of providers that evaluate them. It's a very comprehensive process, but what we want to do is determine, are the alternatives going to provide any sufficient options to help them manage that chronic pain other than any kind of drug use. So we're in month number 5 of that project. So we've seen about 11 patients of the 20.
Okay.
So those are the projects that we're currently working on.
And did you see the VA study on alternative pain?
Actually, we just got that. I read it the other day,
It's
yes.
fascinating, isn't
It
it?
is.
That basically Aleve and Tylenol or whatever,
exactly.
the inflammatory drugs do
Yeah.
better in the long run than the opioids.
Yeah. The other things that we're using as alternatives, and we're really encouraging, are aquatherapy, yoga,
Sure, yeah.
mindfulness training, tai chi, those types of things, and trying to avoid resorting back to any form of medication.
Good.
So we don't have the results yet because we just put the first batch of people through and they're just starting their therapies. So we'll know a lot more in the next 6 months. So,
Good for you.
yeah,
That's
so,
really exciting, yeah.
yeah, we're enjoying that project and we're learning a lot.
Mhm.
So, yeah.
Who else?
We got lots of people filling this.
Yeah.
We're doing a lot of things as a community, not just on drugs. Our vendor here can talk a little bit about our CHIP program, which is our community health improvement.
Oh, that's different than the Children's Health Insurance Program.
It is. But a lot of people use the same acronym.
It's been funded for 10 years, double the longest it's ever been funded before, so that's good.
It's a marvelous thing.
Yeah, it's in place.
But our vendor, maybe you could talk about.
The other
some-
CHIP.
The other CHIP.
So where do I start? So the CHIP department works, so it started just focusing on launching any projects or programs that will benefit the community. And I also work closely with the local community advisory council. So during the start, the focus was on senior health, mental health, dental health, and physical activity. The focus is pretty vast as it is, but since then, the focus has broadened even more right now. So last year I had also conducted the needs assessment, finding out what the priorities are in Lake County and kind of focus my time more on that. And yeah, I have been launching a lot of programs, getting feedback from the advisory council and also from the public. I work closely with Valerie and Sky Lakes at Klamath County, and so we have launched these workshops, free workshops for diabetes patients, for chronic conditions. And last week was our first session for chronic pain classes. We advertise in the community. We also have provider patient lists from where we get our participants. And yeah, so I've been working with Sky Lakes. We have been doing those workshops. I've been focusing on food security. So we have a summer food program. This was our second year of the summer food program, handing out free lunches to children. Also focused on physical activities. I work closely with the OSCU Extension Office. And we had a 7-week course where we taught children so that they could take part in the yearly marathon that we conduct in Lakeview. And yeah, mostly just, I also work closely with the clinics on several of the measures. See to it that our numbers are going up and also provide good incentives for people to take part in it. And yeah, and as Trace had mentioned, I'm also working on the housing crisis for now, we are planning to conduct a housing study. We are trying to get a lot of community and health partners together because we just don't know how to navigate through that problem.
What do you find on the housing issue? Because this is an issue all over the district and frankly all over the country right now, is affordable housing.
So for now, we have found out that it is one of the main priorities in Lake County. And it's such a vast problem and no other counties around us has ever found a solution to it. So for now, what we have decided is to...
That sounds familiar.
So for now, we have, the first step we want to take is to conduct a housing study, where we get more information of how to tackle the problem in the future, how to go about it. It's a 3-year plan that we have thought of. What we know for now is, again, Lake County, most of the residents are pretty spread out. It's 8,000 square miles and I think the population is also around 8,000 people, 1 square mile per person. So we know that there is a housing crisis, but for now we are just trying to do a housing study and then we know how to go about it.
One of the challenges we face is if the wellness center takes on a patient who has been in crisis, we can't even find a place for them to go and stay sober. We can't, it's in all realms of housing. When we try to recruit people, we can't find them a house to live in. So people here that are working can't find, and it's difficult to find. It's difficult to find places that are accessible. So as we think about when we define what that crisis is, where do we put our seniors that are living out on the ranch that need a place to go? They come into the senior center in town, and that's really good for socializing and for nutrition and
Then they
whatnot.
drive 50 miles back out.
It makes it difficult. It makes it difficult. And without a doubt, Portland vacuums up all the real dollars for housing. They have their own crisis.
Yeah.
But rural doesn't get much help when it comes to housing. So it's a big issue for us.
Yeah, it literally is everywhere, whether it's affordable workforce housing or senior housing or. Thank you.
Outback Strong is the name of our group that we have developed to try and promote healthy lifestyles and deal with lots of the kinds of issues we've been talking about.
And under the CHIP department, we also have tried launching this positive social norming campaign to fight the various stigmas we find in Lake County, and yeah, just to change the perception of there's nothing wrong with asking for help or visiting a provider for health-related issues.
It's got a picture of your colorectal cancer.
Yeah, we call that Nolan the colon.
No.
Raise them.
Yeah, every decade I get to that. It's great fun.
Another thing we're working on, and Teresa could talk a little bit about, I pointed out our classroom that we have with nursing, the synchronous class. Teresa can talk a little bit about a new program we just started for nurses, the rural nursing program.
Excellent.
The Rural Nurse Residency Program, I think you wrote a letter of support for us and applied for a grant for that. We did our first program this fall after the nursing graduates had finished taking their tests. So we're focusing primarily on new graduates. They're out of nursing programs. There's a lot of data that talks about nurses drop out, actually completely out of the profession within the first year of practice. And certainly there's a lot of migration out of their first workplace. So looking at that, looking at the causes for burnout and the support that we can offer them, the nurse residency programs that last over a course of 3 to 6 months, some even as long as a year, have been shown to reverse some of those things that change whether or not nurses are retained, which is a big thing for us. Not only do we have a hard time finding them, then we have to keep them. So it's been really successful so far. It's our first go at it, but in doing that, we've been working now for several years with Klamath Community College to have the classroom. So our local people didn't have to commute to attend class, and now we, just this past year, have worked on having them also do some of their clinical rotation here in town.
Perfect.
So there's a lot less travel. And then we are now in discussion with the OHSU nursing program at OIT in Klamath to do a similar type program. And that's what we hope the grant will help us do some of that under the technology that we need to make that possible. So we're really happy with how it's going so far.
Good, good. Well, it seems to me all the evidence shows that you can train people in communities they live in today. Your odds of keeping them are much higher.
Especially in rural communities, because it's such a culture shock to
That's right.
move to a rural community.
Some people just can't take the utopian nature of life in the world.
Well, the other part is that people have changed in careers, and they're already living here, and they may have a family established. We accommodate them.
Yeah.
And that they wouldn't be able to otherwise stay, they'd have to leave the community because if they can't find a job in a rural setting, but it could be a nurse or it could be a healthcare
Yeah.
practitioner, they can get that skill staying here. That's a positive.
Yeah, well, absolutely.
So, did you want to say anything about the senior center?
I'm more and more interested in senior centers these days.
Well, I'm here on behalf of the senior center, but also we operate one of two transportation programs within the county. And that's how I'm interested in the grant and involved in it on the transportation aspect. So we currently have a contract with GOVI to provide non-emergency medical transportation for those clients. We also have a veterans grant.
Good.
We're very lucky to receive
What does that allow you to do?
transportation for medical appointments for veterans and a spouse or caregiver, which in those, we call them the VA vans, the red, white, and blue, you couldn't take your wife, or they had to be a designated caregiver, kind of specific. And the van that was here, or I think it still is here, but doesn't have a wheelchair lift or any of that, which our vehicles are handicap accessible, so that part's nice.
And how far can you transport under your grant? What's yours? Can you take them through to White City, or is it?
Yes.
Yeah.
And in fact, we have a trip scheduled to Portland. We don't usually do overnights,
Yeah.
but there's an individual that's needed. So White City, yes. And we have two drivers located in Summer Lake, so the north part of the county, that are work with us. And they take a lot of people to
St. Charles or something. Yeah.
there's
The clinic there is, yeah.
So that's going good. We have ODOT funds that we also receive to transport individuals. But there's a great need for transportation. And as you probably know, you drive so far to get to anywhere from here or coming here, or
Yep.
so we're always looking for ways to coordinate with other agencies or other funding to get more and more people where they need to go for medical care. So the non-emergency medical is awesome, it's paid, and then we have a couple of other individuals who are trying to get really creative with scheduling to get, 3 people going to Bend or to Klamath Falls, or where that wasn't happening quite so successfully before.
The VA's changed up its scheduling system, I'm told. Yeah. Is that helpful? Where you have more options to pick your appointments and all? Not really.
And it's also, conversation is good. And some of the seniors, that's not their, if the doctor says they need to be there at 8 AM in White City,
They just
they're
say
gonna-
yes.
that's what they think, you know, so
Yeah.
we've had, if they'll allow us to, make a few phone calls and maybe we can push it back to 10 or, you know, it's more user-friendly for an older adult, our drivers as well, you know. But,
It's interesting, there are some private sector initiatives in healthcare that allow, you know, once you're in the system, you can just go online and say, this is the kind of position I want, or whatever, and it's like, poof, up comes all the options, in bigger areas, obviously, but you'd hope we could get to that, to maximize provider time and patient convenience, and integrate that into the VA. Yeah, I've got a retired Marine colonel who finally decided to start using a VA, and he had some basic blood work, and it turned out at White City, let's say they do their blood work on 1 day a week for everybody between 4 hours or whatever, and everybody gets scheduled to be there at 8 o'clock. And it's like, what? So he's working with them to try and do this.
some of the private providers are a little more user-friendly.
Yeah.
Yeah. It's a work in
The
progress.
VA does not lack for bureaucracy. We're working on it, we're not there yet.
One of the challenges we do face is, since we don't have public transportation,
Right.
is how do we get people from one place to another? And time and again, physicians say to me, why don't you start up a transportation business? It's like, really? Who's going to pay for this? Because we don't, it is so difficult, we're thankful that we have some transportation for medical purposes, but lots and lots of people can't get that. All right.
You know, the chairman of the VA committee, Dr. Phil Rowe, has talked about how could you turn unused bed space in existing hospitals into VA beds. So let's say you've got, I don't know, I'll say 10 beds here, you can almost wall off and go, those are my VA beds. And basically have a VA hospital in every community. And really get access to care for veterans where they live. And you better utilize the existing infrastructure. Then you don't have to worry about taking them to White City or somewhere.
We'd be in favor of providing that service, I'm not sure we'd wall them off.
Well, but that's all on paper.
Right. Right.
Just technically wall them off. In effect, you'd have 3 beds or 5 beds, and there'd be a way to.
Sure.
So the prototype for that is already in place, sort of with the swing beds
Yeah.
in the critical access hospitals. It's essentially that on paper bed that you can
Exactly.
move around.
Yeah. Well, they structure the VA system so that would,
A little different.
yeah, so that they could, this would basically be a swing VA bed if you.
Right,
Yeah, it's not physically walling at all.
because right now they don't let us keep them.
Right, or it counts against
Right.
your critical access number. We tried to change that. Get,
Well, while we have a few more minutes of your time, because I know your time is precious, I want to tell you about something that is important to me. 340B.
Yeah.
We recently had our 340B audit.
Oh, you're one of the few.
We are. So we take great pride in the fact that we are paying attention to this. And we had a big survey, big report, and they found one patient had gone to the Walmart in Klamath Falls and got their 340B dollars or their medication they shouldn't have. So all the survey, all the work that went into it, we spent months getting prepared for it, and they found one patient that Walmart had to return the money. So I know you were have been concerned that there's lots of.
Yeah, we did an investigation on the oversight investigation subcommittee.
Just saying that.
No,
our experience has been, yes, there was one patient. It wasn't a terribly expensive medication.
No, and I think, and I've said all along, I think we find that in most of our rural hospitals, we don't have an issue in Oregon. There are some parts of the country, however, they game this system really badly. And what our data showed was there's been this enormous expansion of 340B in the last few years. And to audit every 340B facility with the existing auditors, it would take 65 years. So count yourself lucky they won't be back for probably 66 years.
I would just encourage that they go to places that are bigger.
That's right, that's right.
Because, anyway, the 340B dollars are valuable. Right now, it represents about $150,000. I know there's a push to try and identify specifically what we use that $150,000 for. Right now, it goes into support all the efforts that we have. But it's a valuable thing to do.
Yeah, part of it, there was a court decision that really precludes HHS from any enforcement capability. There's no, what the Government Accountability Office auditors have told us is there's no standard for how the dollars should be used. There's no consistent definition for how they should be used, and there's virtually no, there's very little transparency. So there are facilities that are, we had some pretty bad apocryphal stories, at least individual stories of things from providers and some hospitals. And so I don't know if you've read the report or not, but yeah. There's some bad things going on in some places. But in most of our hospitals, I can't imagine the world compares, and having been on a hospital board, but it's, you know, it's a valuable program from my side. So
We really, really.
I did not give you your name to audit, by the way.
I was just wondering.
When did they start that audit?
Well, I just got the report, but it was in July. And
Oh, just this year?
She came July 5th. It's like, really? Anybody would travel on the 4th of July to get here?
They're dedicated.
You know, are you seriously doing that? But,
That's fascinating, it shows you.
yeah. So.
But literally, they have, I think they do 200 audits a year or something, if my memory serves correct. So, and there's just been this explosive growth in 340B, and then you've got these satellite clinics that are claiming it too, and then there's some gaming going on around the country, and it's like, whoa, what are we doing here? Where's the money going?
But.
Because we also had situations where patients were actually probably paying more, not getting the savings passed through.
Is that right?
Yeah, there's some of that going on. And some situations where because you get a 50% discount, that our investigators were told, we can never get our hands fully on it, that there were situations where people in the hospital were being told, actually you want to prescribe that drug because we get a $500 rebate as opposed to that one where we get a $50 rebate.
Predominantly.
So, don't think that happens a lot, but.
Predominantly, we use this for the high value dollar for the infusion therapy. And that really makes a difference for people that have very expensive medication that they need.
Yeah.
So it's really valuable to our community.
No, it is.
Could we tell you something more that you'd like to hear about the kinds of things we're doing?
What did we not get to?
Wait.
Oh, yeah. You want to?
Sure. So one of the things that we've been investigating in the committee was we had heard some anecdotal, and then subsequently we've had additional information from different hospitals that there weren't enough rape kits, and particularly in small rural communities, that there weren't nurses that were able to administer the rape kit, and that the hospitals didn't have them, and people didn't know where to go. So in urban areas, it was people didn't know where to go, and there'd only be 1 or 2 hospitals that had rape kits available. In rural communities, there would be the nursing, trained nurses to administer the kit, or they didn't have the kits. So we've been doing kind of like a larger investigation into the number of hospitals and asking these kind of questions like, do you have rape kits? Do you have the nurses? Is there a place that you can go to find that? So it's been something we're kind of concerned about, so.
So to do the rape investigation, you have to be a SANE certified nurse. And the SANE certification is very onerous. And so the way it has developed over the course of time here is we have one family nurse practitioner who can do that. Because you not only go through the training, but you have to do so many cervical exams in a doctor's office to be certified. So it isn't your average nurse that could get access to that kind of experience. That's the impediment, is the way that, the regulations require that to be done. So we have the kit, but we don't have the trained nurse. We've given up on trying to keep anybody within our ER as far as a nurse, up to speed and certified as a sane examiner.
So we've heard that. So what would be the solution to that?
I guess the solution would be that the training would provide everything that the nurse needed to do. She wouldn't have to go on and go to do some sort of additional training in a doctor's office to be able to do the cervical exams. And maybe it's not so, I think it's offered occasionally. It's been a while since I paid attention, but maybe quarterly or every 6 months there's a class offered in the state. So it's not exactly very accessible or available. And what's required is and there's a reason for that. I mean, forensic evidence needs to be perfect in order to convict. So we do need to be really careful about it, but it isn't very easy,
Particularly in the rural community,
especially in a rural community.
Is that not something that could be embedded in nurse training, education along the way?
Probably not. It's a skill you would have to keep up on, and it's not really a part of what we're trained to do. It's more of an advanced practitioner skill. And then I guess part of the problem is that we don't have them all the time. So we use Klamath Falls as our fallback if we have to go there, if our one practitioner's out of town.
So how does that work then? A victim comes forward and you have to transport them to?
Law enforcement. And it's difficult because that person generally needs to be with females. And so that presents a barrier to getting the evidence.
How often does that happen here?
Every few months. And sometimes it happens to men. I mean, and sometimes we're having to do the forensic exam on both the perpetrator and the victim. So there's all these pieces to it. And I know if we don't do it well, then the court, the case doesn't hold up. So I don't know that I'm totally answering your question. I don't know.
No, this is helpful.
Precisely the problem, yeah, we wanted to.
The CARES people from Sky Lakes, that's the organization that oversees this program, have said that if we had an additional examiner, you could expect a peak in reporting. Part of it is we don't get enough, to answer your question, those are the numbers of cases that are reported, or that come forward. There are many other, there could be, we don't know how many are not reported or not acknowledged. And so that's an even sadder situation. It's a hard thing to do.
So it's like it's an addressing issue. More things for the to-do list. Well, congratulations on your grant, that's pretty exciting. In the opioids legislation, we funded, I think, $6 billion going forward. Part of the money for the grant you all got came out of the reauthorization funding for community health centers. We did 2 years record funding. We're going to go back next year, do it again. And then part of it's from legislation we did 2 years ago, 16. We put $1 billion forward for opioids. But money that will eventually flow from the legislation that the president just signed into law will come in the next several years.
That will address more than just opioid.
Oh, yeah, it's all, yeah. And it's soup to nuts, the legislation, so it's trying to stop the illegal fentanyls from coming into the U.S. by beefing up our inspection capabilities at international mail processing facilities, to better reporting of what's scheduled to come into the country, better coordination with customs so it never leaves wherever it's coming from if we don't know what it is, to all the way over here to the treatment side and alternative pain management, investment in alternative in theory, non-addictive pain medication, as well as other therapies, and expansion for Suboxone administration to far wider provider classes. I mean, it's dealing with ER, it's dealing, it was interesting when in Pendleton we had a conversation about like people in the jail and what happens when they come out and who kind of helps. Because sometimes that's your detox facility and your treatment facility. I mean, the biggest mental health facilities in America, tragically, are our prisons. They literally are. And one of the things we did, for example, for juveniles, if they were on Medicaid, they were turned off once they went into detention. And then they had to completely reapply when they came out. We changed that to say you're eligible unless you're not. In other words, if your economic stand, I mean, if you know.
That's just juveniles.
Yeah, for now, it's just juveniles, but, yeah, we tried to get as much as we could. We'll go back and keep working on that. And so that they automatically are requalified once they come out of detention. So you have a continuum of care. But there's just a lot we're trying to expand access to. There's about 75 different pieces of legislation that went into this package. And incentives to educate people in place in rural communities, for substance abuse, behavioral treatment, sort of like you're doing with nurses here, but for others, so you do some loan forgiveness and things of that nature. So seldom can you say a bill has changed and will save lives. This one I think will. I really do believe it.
So when you get on top of opioids, last week, the board heard a presentation and we were told that the next public health crisis coming down the pipe was cirrhosis of liver amongst millennials. So
Well, there are a couple of them. Hepatitis is one that is a big one I want to look into because I guess I think it's hepatitis. I may have that wrong. It's like 9,000 solves it. Is that what I'm thinking of? Is hepatitis C? It was me. I hadn't been about a year ago. Health officials. There's something Oregon's stepping up on, literally for like $9,000 treatment.
Oh, yeah, that's Hep C.
Hep C, yeah, it is hepatitis C.
9,000?
Yeah, for like $9,000, you can get the medications now.
Down from 139,000
Yeah.
for
Wow. And basically, you could eradicate Hep C, which is far more prevalent than opioids, and but that's interesting on cirrhosis. I have not heard that. Is that driven by microbeer consumption in excess?
I think just
So it
excess.
might just be the same.
Yeah, Pendleton Round. We're not naming names here. It's all filming.
That was stunning to hear, wasn't it?
yeah, it was stunning. The numbers.
Wow. We also passed something called PAPA, the Pandemic All Hazard Preparedness Act, that deals with the nation's readiness and response mechanisms for chemical, biological, and pandemics. And they're all very, very real threats. But pandemics would be like the flu strain, Ebola, Zika, any of those things. So it is not only how do we acquire the antidotes, how do we invest in the research, who does the distribution if something happens. It's one end to the other of the supply chain, where are the pallets ready to be lifted out, and who manages the supply, the interaction with CDC and HHS. And so anyway, that's a whole other one to keep you awake. We had a classified briefing on it. Every time one of my colleagues would ask a question, we'd go, thanks for that. That's what you need to know. Bad actors in the world, I'll just tell you. So there's a lot of that work. And of course, we doubled down in the spring on the investment for NIH research too, another $2 billion. Yeah. So there's a lot of money going into trying to find cures to the 7,000 diseases for which we have no treatment today. And through NIH, and those grants, of course, go out to HSU research facilities. And they're making some real progress. So I was with the head of the NIH the other day. He was down at the White House when the bill was signed. You meet with these folks at the top, and they are really excited about what's just over the horizon with with mega data that we have now and the ability to harness, cloud computing and all the data on us, they're able to go through and figure out molecules that work in seconds where it used to take years and millions. It's really phenomenal. And they're pretty optimistic. Well, we appreciate your input. Let me know how we can continue to be helpful on these matters. Happy to lend
This was
a
very,
letter of
very
support.
Greatly
And just
appreciate
to
it.
close the loop on the two questions you asked me, the funding for the veterans programs, we also are increasing the Mission Act, which would also bring more money to those. So yes, there's more money going to them, and they'll be able to, through the Mission Act, be able to go stay within the community and not have to go back to the VA facility. So I got that back.
Good.
And the second is Merkley signed a letter in support of the Part
Oh,
2,
that's right.
but why didn't state silent?
Okay.
So.
All right, I forgot, yeah, that makes sense. So Jeff is,
So Biden was silent?
or at least not on the letter.
Yeah, I think he never stated an opinion because of the process, so I think he was just,
You get a lot of these letters flying around.
yeah.
I don't know, they show up at like 4:59 and they go, you got till 5 o'clock to decide. It's like, so, I wouldn't read too much into his absence from that letter, but it's worth touching base with him.
Okay.
Yeah, I'd forgotten Merkley came on board.
Yeah. But there were only 7 that signed that letter.
Oh, is that it?
Yeah.
Okay.
So.
It's one that they just need more education, because once you get into it, you realize the risks that are there and the patients that are suffering as a result of this lack of information flow. It's like, we're not talking about light to be used to discriminate against you for any purpose. We made that really, really clear. It's statutorily clear. So, tougher than that. But thank you all, we appreciate it.
Thank you.
Thank you.
Keep up the good work.